announcements today. And first, I'm going to say, look around you and you'll know who the obsessive compulsive people are because all the GI people are already here. I told Tad, look, Tad, everybody else walks in at 8:05, but so hopefully we'll have some people come in. I have an announcement. There is a liver symposium that our section puts on every year, and this time it's going to be from 8 a.m. to 3 p.m. this coming Saturday, the 8th. You can go to our website. There is CUE that's offered. You can look at the topics. It's going to be everything and anything in liver, and it's very, very enriched with information that's clinically useful, as well as stuff coming up for management, new management strategies for our patients. So please join us at the symposium, and it's in the CTR building. Today I have the pleasure of announcing an internal speaker, Dr. Dryden, who I've known since I got here. He got here a few years before me in 2000, and I remember a few months. I remember the division chief saying, and Dr. Dryden is a breath of fresh air, and he's a breath of energy, like the Tasmanian devil type energy, but it's really good. I know he has a military background. I'm not going to go into his background, except when I ask every speaker, what are you most proud of that you've achieved? And you know what he said? That I have 3 daughters that are ready to get out in the world. One is graduating from medical school here, and she's Sarah, and she will go into the Navy. One is graduating from the Naval Academy and is going to fly jet planes. And one is in the Marine Corps as a lawyer, going to be deployed to Okinawa. So,
thank you. So, and I would also have to say, my wife, picking the right person to be my wife, that helped a lot as well. That she said yes. That's what I'm most proud of. So, anyhow, thank you all for coming. I have a lot of GI fellows in the audience, which is good because this is going to be primarily directed to them on how to care for their patients down the road, but there are also important aspects of this talk to be able to take back to your patients, even if you are taking care of them as a primary care doctor, to make sure that they're getting the appropriate care from their gastroenterologist. And the primary care doctor can certainly be a watchkeeper over making sure that their patients are getting the best care available. So the topic, biologic warfare and inflammatory bowel disease, time to increase the defense spending, really comes about from the fact that, you know, we're in a whole new era at this point in time. We have very expensive therapies. And if you think about depleting the defense budget, what happens? You wind up having problems, you have training accidents, you wind up having people that are trying to take advantage of you, you have not such great outcomes. You increase that defense spending, then you obviously wind up having the best military in the world that is capable of defending against all foes, imagined and real. So if we're going to talk about spending money in inflammatory bowel disease, it's basically going to be centering on the biologic therapy that we are developing to take care of these patients. So what I want you to do today is appreciate the changes in IBD demographics and understand the cost of care for these patients, really, and identifying the drivers that are increasing this economic burden of inflammatory bowel disease care. So I'll throw up some numbers soon that are pretty impressive. We'll talk about discussing strategies for optimizing current therapies, and then we're going to understand the ramifications of endoscopic improvement and histologic remission on IBD outcome, because that's really the driver of quality care for these patients. So as Dr. Roman always wanted us to do, I think that carries over into the present era. Start off with a case. This is a representation of a case that I've seen in clinic in the not too distant past. So Susie is a 28-year-old Caucasian female who was in previously good health. She presents with a 5-month history of intermittent abdominal pain, bloating, change in bowel habits, and weight loss. You can already start forming a differential diagnosis in your mind, I hope. She's never smoked and reports no family history of GI problems, and her only medication at the time is an oral contraceptive. While she was on a trip to Ecuador, Susie experienced acute onset of non-bloody diarrhea. It resolved in about 24 to 48 hours, and her current symptoms that she's presenting with began approximately 4 to 6 weeks after her return home. She reports up to 8 bowel movements per day that have become very loose. She has associated that with about a 10-pound weight loss since the symptoms began 4 to 6 weeks ago. And her abdominal pain is present almost daily, and it's progressively worsened from the time of onset. Her laboratory evaluation to date includes a mild anemia with a hemoglobin of 10.1 grams per deciliter. She has an elevated C-reactive protein at 17.2 milligrams per deciliter, and her stool studies have been negative for enteric infection. So her most likely diagnosis, I'll just take a show of hands since we don't have clickers. Who would? Okay, the build failed me. All right, so celiac disease. This could potentially be something that you would consider. Diarrhea, weight loss, usually not associated with abdominal pain. Irritable bowel syndrome is certainly common. Up to 25 to 30% of patients that develop an acute enteric infection will wind up developing subsequent irritable bowel syndrome, usually diarrhea predominant irritable bowel syndrome. Her weight loss is concerning for irritable bowel syndrome, though, because that's a non-functional symptom. Small bowel Crohn's disease. Certainly, patients who experience an enteric infection can often have that serve as a trigger for development of inflammatory bowel disease. And amoebic colitis is something that could potentially be going on, but she was in Ecuador, so if you know anything about the amoeba that are in Ecuador, most of them are actually dispar, and those are usually not pathogenic. They're not the pathogenic organism. But small bowel Crohn's disease would be the thing that would be running through my mind most prominently. I would also consider that. And what are we going to do when we are thinking about determining the etiology between those two different things? Of course, we're going to do some diagnostic work, right? So a colonoscopy reveals large, deep ulcerations here in the terminal ileum, and pathology confirms that this is consistent with a chronic active ileitis, and there's no evidence of infectious organisms. An MRE actually demonstrates a significant amount of inflammation in the distal 25 centimeters of the terminal ileum. So again, we have a couple of things that are building here to give us consensus for inflammatory bowel disease. So what's going to be the next best course of action for this patient? We're going to let her do, or we're going to let her maybe burn out, or we're going to treat her with medication. Of course, we're going to treat her with medication to try to get symptomatic relief for this patient. So, show of hands before I burned the build here. Oral prednisone, steroid taper, and azathioprine. Who wants to go with that? Wow. Either everybody's stoic or that everybody's well informed to begin with. How about oral budesonide 9 milligrams per day? It's a not relatively minimal systemic side effects associated with treatment. It's certainly well known as a treatment for Crohn's disease, ileal Crohn's. How about initiate anti-TNF plus azathioprine? Okay, one taker, two takers, so okay. At least this patient's going to get something for their disease. How about colorectal surgery, a consultation for resection of that small bowel? No? Okay, so certainly C. Now, why did we pick C over prednisone? Prednisone works well, it works for most patients, and it's been around for a long time. We know the side effect profile pretty well. We taper it and we follow it with azathioprine. Why not that? Well, it's because it's not the best choice in this day and age. So this is a combination of measurements here. So if we think about the inflammatory burden of a patient, especially somebody who's newly diagnosed like Susie, she's probably had a little bit of inflammation going on in the past, but this brought it to the forefront here for her as a trigger. And so she now has a flare of active disease as evidenced by her clinical symptoms, or if we were to measure a Crohn's disease activity index, that would be elevated. C-reactive protein was elevated for her. If we would go along with the course of her life, she's going to have probably multiple flares over the course of time. Now, the problem is not necessarily in the flares because we can take care of those quite well. Prednisone works great for flares. The problem is that if we don't abate these flares or perhaps dampen them over the course of time, if you look over here, this digestive damage score, the Lamont score, is a cumulative score that adds up the damage to the bowel. So typically looking at strictures, fistulizing disease, things like that. The problem is over time, Susie's going to wind up developing complications with almost 80 to 90% degree of certainty that she's going to wind up having complications. And generally, they're going to require surgery to resolve. And so we want to try to prevent that. And we know that there is probably a window of opportunity before she develops these severe complications, such as strictures, fistulizing disease, where we might be able to actually change the course of her disease process. So how do we do that? Well, one of the things is providing effective therapy. But even the most effective therapy, if used incompetently, is not going to give us the desired results. And so we have to start managing these patients with a concept of tight control and monitoring to be able to get the best result out of our therapies. And again, if we're spending our defense dollars, we don't want to spend them on a $420 hammer. We want to spend them on the $1 million missile that's going to be able to take out somebody that we want to take out with precision. So if we look at that initial diagnosis for Susie, it might have been a fairly severe one, but if we can actually use those tight control management principles to be able to prevent her from having additional flares, we may be able to settle out her disease activity to the point where she doesn't wind up developing complications, disabling complications from her Crohn's disease, and therefore change the course of her life. So we have some pretty good ideas about what patients need to be able to define a severe or a patient that's going to have a high risk of disabling complications. So multiple sources of data suggest that if we have age less than 40 years at the onset of disease, that's a high risk factor. Patients who smoke, so that's pretty common for our patient population here in Kentucky. Patients who present or within a short period of time develop a perianal fistula. That's a bad sign in Crohn's disease. Anybody that requires steroid therapy early in the course of the disease, i.e. 90 days. Patients with a high risk disease anatomy. So that would be a patient with ileal disease only, or small bowel disease in the upper part of the digestive tract, such as the duodenum, perhaps the stomach and the esophagus. And patients who have deep ulcerations on endoscopy. All of those have been shown to be indicators that the patient is going to have a more severe course. So prednisone and budesonide are appropriate choices for patients with mild to moderate with a mild, without additional risk factors to be able to symptomatically control their Crohn's disease. But based on Susie's disease characteristics, she has many, her age, need for prednisone at the onset, also some deep ulcerations. Steroids alone, plus or minus azathioprine, is really not appropriate. So we're going to move on to that azathioprine plus anti-TNF. And why do we use combination therapy? We need to have aggressive therapy to be able to quiet the disease symptoms very rapidly. The benefit of immunomodulators plus anti-TNF during both induction and maintenance of remission has been shown in retrospective analyses in multiple trials to be more beneficial than monotherapy alone. So that informs us with one degree of evidence. If we look at both adalimumab plus infliximab, we see that is a common theme. And then we had this groundbreaking SONIC study, which actually prospectively evaluated patients that were like Susie, that had an early diagnosis of steroid-requiring inflammatory bowel disease, Crohn's disease. And these patients were either randomized to azathioprine, infliximab, or a combination of the two. They were evaluated for steroid-free remission in this prospective clinical trial. And the conclusion was basically from all these sources that we have synergy with two medications in combination. And if we look at the data for that, that study, for the SONIC study, you had to be at least 21 years of age, moderate to severe Crohn's disease, no prior exposure to biologics or immunomodulators, and you had to have a normal TPMT, which allowed you to have the adequate dose of the azathioprine that we need. They were randomized to one of three arms, either azathioprine 2.5 milligrams per kilogram per day, Remicade 5 milligrams per kilogram, or a combination of both of those doses in one patient. And they were allowed to have prednisone up to week 14 to be able to acutely control their symptoms. But then we were evaluating what happened at a later point in time down the road. So our primary endpoint was steroid-free remission at week 26. And again, the groundbreaking novelty of this was the fact that we found out that azathioprine monotherapy was pretty lousy. Actually, we confirmed that azathioprine monotherapy was pretty lousy at controlling disease symptoms. However, infliximab monotherapy wasn't that much better, about 50% better. But if we look at the combination of the two, we can actually double the azathioprine monotherapy rate of steroid-free remission up to 56.8% with the combination. Now, if we look at an important secondary endpoint, mucosal healing at week 26, we can see again that azathioprine is a pretty lousy monotherapy with only about 17% getting that mucosal healing. And we double or tripled it based on whether you were using a biologic or a biologic in combination with azathioprine. So again, this is a pretty good number here, 44%. Keep that in mind because we'll be talking about that a little bit later down the road. So why do we need to increase defense spending? Well, it's because we have a pretty large number of patients with inflammatory bowel disease. Overall, we have about 1.2 million patients in the U.S. that have some form of inflammatory bowel disease, more Crohn's than ulcerative colitis. That total increases by about 70,000 patients per year. So these are new patients that are more like Susie in the fact that they haven't had probably inadequate care for a number of decades leading up to the point where they've had complications. They actually have a fresh palate that we can use our new evidence of taking care of these patients to be able to hopefully change the disease course for them. The peak onset for Crohn's disease is usually in the 20s and 30s, and so this tends to be a young onset disease process, but they're going to live with it for a lifetime. And so, again, in order to keep them from getting complications down the road that could potentially be disabling to them, we have to be very aggressive early on in their disease course. And ulcerative colitis has a little bit later onset with a peak incidence of about 30 to 40 years. But the problem is we have this increasing cohort of elderly patients as well. And we know that combination therapy may actually have problems in elderly patients because they may be more susceptible to the infectious complications or the oncologic implications of being on azathioprine for long periods of time. So given the low morbidity in inflammatory bowel disease, we also have these people that were early onset that have now graduated into being old folks with their ulcerative colitis and Crohn's disease as well. So if we look at the economic burden of inflammatory bowel disease, we're not quite at defense spending levels yet, but if we look at IBD, it's one of the 5 most expensive to treat disorders in the U.S. So we have a pretty small population. You know, we're not even talking about heart disease. We're not talking about stroke. We're not talking about cancer. We're talking about this 1.2 million patients with inflammatory bowel disease. And it's also the lowest prevalence of GI disorders that we commonly think about. It's not GERD. It's not irritable bowel syndrome. We're at 10th of the number of patients with irritable bowel syndrome. But the IBD financial burden is about $15 to $32 billion, which is actually probably an underrepresentation of the overall burden. And it's a fairly common reason for patients to be in the hospital. So about over 100,000 hospital discharges listed IBD diagnosis first in 2009, but over the course of a decade, that number of admissions actually doubled. Now, good news is that the most recent CDC mortality and morbidity report actually suggested that elderly patients are having a decreased number of hospitalizations for inflammatory bowel disease. But in that one decade where we doubled the number of discharges at a mean cost of $34,000 per hospitalization, we actually are spending about $1 billion just on the hospitalization of these patients. So this is a high dollar target that actually has room for improvement. If we look at the cost estimates for hospital visits in 2010, by another source here, the CDC, we can see that ulcerative colitis is about $107,000. Crohn's disease is even higher at about $187,000. And that tends to be because these patients have prolonged courses taking care of these fistulas and things like that. So if we look at the overall economic burden of inflammatory bowel disease, the direct costs are mainly driven by hospitalization and prescription and over-the-counter drugs. Physician services do come in here, diagnostic procedures come in here, skilled nursing and other procedures. But the rise from 2004 at $6.3 billion per year to 2014, $28 billion per year shows that there has been a dramatic rise in the amount of expenditures for this disease process. So where did this come from? Well, it came from the fact that we need to spend more money on more advanced weapons for this disease process. So if we look at the cost breakdown for taking care of these patients in 2004, it was about a third with non-hospital, non-surgical hospitalizations, pharmacy utilizations, and then outpatient services. So things were pretty well balanced. At that point in time, we used to be concerned about mesalamine because this was the most costly medication. It was about a third of the patient's medication cost for Crohn's disease, about half for ulcerative colitis because it's really the foundational therapy for ulcerative colitis. But if we fast forward to 2014 now, the defense spending on medications has mushroomed. So if we look at this now, we're almost 50% or half of the overall expenditures for patients with inflammatory bowel disease, dwarfing the outpatient services and dwarfing the non-surgical hospitalizations as well. So if we look at the breakdown, why has this changed so much? Because now about 70% of the expenditures for medications are actually being spent for biologic therapy, for anti-TNF therapy. And at 2014, that was really one of the only biologics that we had readily available. Now the number of biologics is mushrooming. So TNF at that point in time made up about 2/3 of the Crohn's disease medication costs, whereas mesalamine had been pushed out to make up only about 10% of the overall costs. So another trend that we can find in the literature or in the data for these patients is the fact that claims data suggests that 80% of the total costs are actually going to a fairly small minority, about 28% of the overall patient population with inflammatory bowel disease. So with an average of about $46,000 per year, 64% of these claims are actually utilizing the benefits of an anti-TNF therapy. So that's really one of the main drivers of the cost center for those patients. Augmentation is a term that indicates adjustment from index dosing, and augmentation occurs frequently with both 5-ASA medications as well as with biologic therapy. You can see here the numbers, about 20% of 5-ASAs, but biologics up to 50% will actually require a higher dose than what they start out with. But if you disrupt the treatment or discontinue the medication, that occurs in about 50% of 5-ASA initiators, and that suboptimal or that treatment disruption will lead to suboptimal care that actually increases cost by anywhere from 50 to 75%. So we often butt heads with the insurance companies because they stop medication, they don't want to pay for the medication at the doses that we feel are indicated for our patients. They wind up getting off of their therapy for 6 months or so, then they wind up back in the hospital, sometimes with an operation. So the overall challenge here is to be able to maintain optimized care. And we certainly know that dose escalation may increase adverse events, although data really doesn't suggest that, but it definitely increased costs. So that's why it gets attention of insurance companies. But suboptimal care, again, is probably more responsible for driving insurance costs up than optimized care. You can see here the average cost per care per year for optimized therapy for Crohn's and ulcerative colitis, either double or tripling that cost for suboptimized care for those patients with inflammatory bowel disease. So what are some techniques that we can actually use to help reduce or shrink the defense spending other than, cutting out the beneficial thing that's helping these patients, their medications? Well, number one, we can assure that all patients are treated with the most effective therapies. We've already kind of alluded to what those are, the biologic therapies in this day and age. Improve treatment adherence and compliance. A stopped medication is an opportunity for a patient to progress. If we optimize the treatment regimens based on an individual patient parameter, we can then use long-term remission as the goal of care. And if we refer back to the original diagram that I showed with the cumulative incidence of surgery or not cumulative incidence, but the accumulation of defects leading to surgery for an individual, we can actually change the course of their outcomes. And so we want to avoid unnecessary healthcare utilization by decreasing the number of hospitalizations and the number of operations that are occurring for these patients. So how do we do this? Well, I already told you that combination therapy, in this groundbreaking Sonic study was shown to be the best way to go. But is that really true? If we go back and we look at the data from 206 Sonic patients that had infliximab levels at week 30. And then we break them down into infliximab monotherapy versus combination therapy. It turns out that the patients who are on infliximab alone tended to be the ones that were most highly grouped in the first or the lowest quartile for drug levels. So these patients had a drug level that was quite low, less than 0.84 micrograms per ml in a trough level. If we look at the patients that were on combination therapy, most of those were actually grouped in the fourth quartile, which is the highest drug level, and their average level was at least 5. And this gives us evidence to suggest that, so these are proportions of patients, but if we actually look at the patients that were achieving mucosal remission, we can see that the patients who are on combination therapy tend to be higher numerically across all quartiles, but unfortunately there were no significant differences here. But the fact of the matter is the data tells us that patients who are on combination therapy are more likely to be in the higher drug level. And we know from other sources that higher drug levels actually equate to better outcomes for these patients. If we look at a pragmatic trial where we actually evaluated putting patients on monotherapy versus combination therapy to see if there were differences in the outcomes based on that, this is a retrospective cohort study where they looked at 149 IBD patients, where half approximately were started as combination therapy, about half were started as monotherapy. The monotherapy was the standard induction and with infliximab, and then they either went to every 4 or every 8-week intervals for their dosing based on their clinical response. The target of drug monitoring was to have a drug level of about 3 to 7 micrograms per ml. And if you had a flare, a clinical flare, it actually prompted an escalation up to 10 milligrams per kilogram dose every 4 weeks. You know, the insurance companies don't like to see that because that's costly, but in the long term, it may actually have some benefit. The combination therapy got the same type of induction that we saw with the SONIC study, and their goal was clinical remission plus maintaining an infliximab trough level of at least 3. And if you achieve that, you were able to discontinue the azathioprine. So these patients were followed, and at week 10, week 52, and then end of follow-up, they were evaluated for their clinical outcomes, their infliximab consumption, and then also their drug to trough level ratio, which is a measurement of the amount that they're consuming based on the amount of drug that they have in their system. So if we look at drug retention rate by infliximab based on starting therapy, you can see that the monotherapy in yellow versus the combination therapy, presumably for a short term, actually had pretty similar outcomes when we looked out here to out to 60 months. So really no significant difference how you started the medication. If we look at the clinical outcomes based on the starting strategy here, mucosal healing basically had no difference, and about 3/4 of these patients actually underwent endoscopy to be able to evaluate. There was really no difference in steroid-free remission or hospitalizations, and essentially we had no significant differences in the drug to trough level ratio. So whether you started out with azathioprine in combination with infliximab versus infliximab by itself, but optimized to be able to have a certain drug level, you wound up at basically the same place after about 5 years worth of therapy. So no difference in the infliximab trough level, whether you added azathioprine or not, as long as you're monitoring what the drug levels are. So if we think about managing our resources effectively and efficiently, if we think about Susie and her clinical presentation, you know, current evidence would suggest that we need to use aggressive therapy for Susie. We need to use a biologic therapy. The old evidence suggested that we actually needed to use combination therapy. Newer evidence suggests that maybe we don't. How do we tailor Susie's care to improve her outcome? Because we want to avoid those surgical complications, the development of fistulas, things like that. So the concept of treat to target has now been borrowed from diabetes care and rheumatology care to be able to apply to inflammatory bowel disease. This type of treat to target strategy has been used very well in diabetic care with the hemoglobin A1C, and in rheumatology with the use of the ACR score, looking at deterioration in bone quality. So the treat to target concept really was borrowed by medicine from engineering, and this is the concept of a reiterative analysis of what your outcomes are, making changes going back. We also see these types of systems in quality improvement as well, with the plan, do, check, assess kind of thing. So utilizing treat to target in inflammatory bowel disease allows our patients to give them some clear treatment endpoints, so we can pre-specify those based on analysis in clinical trials. We can set up a strategy for being able to achieve those clinical endpoints, and then we have to resolve to commit to this reiterative assessment to be able to make sure that our objectives are met. Now, that sometimes is the problem, because I don't know how many people in the audience have taken a colonoscopy prep, but it's not fun. So patients often really need a lot of convincing to be able to take care of this ultimate evaluation of these objectives. So the targets for treat to target in inflammatory bowel disease could be clinical remission. We've certainly used that for decades. But more relevant may actually be absence of evidence of inflammatory activity, whether that be drug levels, whether that be some biomarker, whether it be colonoscopy. The goals of treat to target are to evaluate for target acquisition for within every 3 months. So you have the patient come in, they get their baseline assessment, you plan a therapy, 3 months later you evaluate. If you've made your target, then you go on with continued therapy as is. If you haven't made your target at that point in time, you have to go back, you have to plan another intervention, i.e. raise your drug levels, do something different, add another therapy on, reevaluate 3 months later. If you've reached your target, you can move on. The practical considerations for implementing this strategy in inflammatory bowel disease, where patients have to take preps on a regular basis, go through colonoscopies more frequently, it's a lot more difficult than sticking your hand in an x-ray machine and getting an x-ray, or getting your finger pricked for hemoglobin A1C. So the other thing is that we're hampered by imprecise indirect measures of activity. So our blood tests, as I'll go through the data, don't work as well as a hemoglobin A1C does. Clinical trial-based approach to evaluate this approach actually makes it very slow for us to be able to understand the implications of these processes. Most clinical trials take 2 to 3 years to enroll, another year to evaluate, another year to publish. So we're 5 years down the road, and we've got tons of new therapies to implement. And then also these different goals may need different interventions. So if you're looking for a drug level, then you may only need to change the interval of the drug dosing. If you're looking for mucosal healing, you may have to implement a whole nother treatment strategy for these patients. So some of the methods that we have for assessing treat to target clients in Crohn's disease include clinical symptoms, biomarkers, endoscopic score, and a histologic score. Really, the only difference is what the scoring systems are between ulcerative colitis and Crohn's disease. So we'll kind of go through some of the nuances as we move forward. Now, we kind of have a guiding document to be able to understand how to apply these treat to target principles to the treatment of inflammatory bowel disease. And that comes from the STRIDE consensus paper that came out back in 2015, where they had a whole bunch of gastroenterologists, 28 IBD specialists who came together to evaluate relevant endpoints for evaluating inflammatory bowel disease. They had to have at least 75% consensus. So in order to do that in a room of doctors is difficult enough, but in a room of IBD specialists, even more difficult. So if they had a recommendation, it was probably a pretty good guideline here. So the things, they had multiple guidelines that they came out with, but they kind of settled into 5 groups. So clinical targets and patient-reported outcomes, that's the buzzword. It's not just you're a number, a score. You actually are a patient with symptoms, and we're evaluating what those symptoms are. We grouped into endoscopic targets, histologic targets, adjunctive biomarkers, and then novel future targets. So we'll kind of hit each one of those along the way. So the STRIDE recommendations for clinical targets and patient-reported outcomes were get rid of the rectal bleeding and normalize the bowel habits. I mean, those are the two biggest complaints that patients with inflammatory bowel disease have, right? So that's easier said than done, because if you look at Crohn's disease, we have the patient-reported outcomes 2, or the PRO2, which includes abdominal pain improvement and diarrhea improvement. We also have the kind of antiquated but still relevant Crohn's disease activity index. And then we have a derivative of that called the Harvey-Bradshaw index, which is commonly used to be able to go back and look at clinical outcomes in retrospective analysis, but it's difficult to apply because there are some holes in the data. If we look at ulcerative colitis, we have a PRO2, which is a little bit different because bleeding is more of a prominent symptom in ulcerative colitis than it is in Crohn's disease. But diarrhea is still a big component, and we want to measure both of those. We also have something called a Mayo Score, which is a score from 0 to 12, with 0 being nothing, 12 being the worst inflammatory bowel disease, and we'll kind of go over that. But then we have a partial Mayo Score. We also have True-Levin-Witz criteria, which has been around since the 1950s. We have all these scoring systems, and there's really no consensus. And some of them work better for certain situations than others. If we look at the use of a clinical symptom indicator as a measure of mucosal healing, because that's ultimately probably our goal for most of these interventions for patients with inflammatory bowel disease. Again, we have decades of clinical trials where we've monitored the clinical symptoms, and we've said that a drug either works and can be on the market because it improves clinical symptoms or not. We haven't gone to the point where we've utilized mucosal healing as an endpoint to get a drug onto the market yet. If you look at the Crohn's disease activity index, it's categorical in nature. Less than 150 points is remission, 151 to 220 is mild, and then 220 to 450 is moderate to severe disease. These are all the factors that go into it, and it's pretty complicated, and people mess up the calculation of this scoring system all the time. But the SONIC trial was reutilized to predict whether clinical improvement actually was able to predict mucosal healing. And in all honesty, it didn't work very well. So if you look at a Crohn's disease activity index of less than 150, it only predicted about 53% of patients who had mucosal healing when the endoscopy was analyzed. And so you could flip a coin and wind up getting that ratio as well. So not a great indicator of whether our patients are improving in a significant manner. Therefore, they're going to still have to have lots of colonoscopies. If we look at the STRIDE recommendations for biomarkers, fecal calprotectin, C-reactive protein, and erythrocyte sedimentation rate are common biomarkers that have been evaluated because they're markers of inflammation. But the STRIDE group says that they're not treatment targets, and we'll look into the reason why. If you fail to normalize, you should probably be endoscoped, but it doesn't necessarily, qualify as a treat-to-target endpoint. We have several that we've talked about. We have some other experimental ones that are coming along, but again, nothing has really been validated as a uniquely beneficial biomarker for evaluating inflammatory bowel disease. So again, the thinking of biomarkers is they could serve as a surrogate for Crohn's disease activity index, which really doesn't work very well anyway, to predict mucosal healing. C-reactive protein has been shown to be elevated in Crohn's disease. It's responsive to improvement in inflammation. You can document that. But if you have CRP normalization, if you go back to that 26-week healing in the SONIC study, C-reactive protein normalization only predicted mucosal healing in 42% of the cases. So it's even worse than the CDAI. Now, if you combine those, I'm not going to show you the data. There was a marginal increase in the ability to correlate with mucosal healing, but not significantly so. All right, if we go back to the STRIDE recommendations here, absence of ulcerations is the target for Crohn's disease, or a Mayo Score of 0 or 1 for ulcerative colitis. Now, on the Mayo Score, the endoscopic component and all other components that go into it are graded on a 0 to 4 scale. So 0 being normal, 3 being severe. If we look at how often to do that assessment, it should be done every 3 to 6 months after initiating therapy. How many people want to take a prep and undergo a colonoscopy every 3 to 6 months? Okay, Dr. Yakishin, you win the award for. Yes, so you've gotten you've gotten the equivalent of colonoscopies regularly, huh? So anyhow, not many people want to do this. We sometimes force patients to do this 3 colonoscopies in a year to be in clinical trials, but for the most part, it's very difficult to do clinically. So what do we have for scoring systems? We had the Crohn's disease endoscopic index of severity. We had the simple endoscopic score for Crohn's disease, the root gear score and Rigera score. Again, these have different implications based on what the outcomes that you're looking at. We had the Mayo endoscopic score, the Bayer score, the Ruck-Milowitz score, as well as other scores that I'm not going to name. The bottom line is we have a preponderance of scoring systems. Again, some may apply to certain situations, but there are some that are used more than others. So if we look at endoscopy as an endpoint in Crohn's disease, this is what I regularly have to evaluate when I'm taking care of patients in clinical trials. And you have to comment on the amount of the size of the ulcerations, the extent of the mucosa that's ulcerated, the extent of the mucosa that's affected, whether there are any strictures or not, and then you have to add up all these components to come up with this composite score. Pretty difficult. I would love to have AI come along and do that as a computer and figure the score out for me so that I don't have to go through the hassle. And it'll probably be more accurate than I am as well. But with all its vagaries, again, if we look at the evolution of endoscopic healing as an endpoint in Crohn's disease, we've already covered the fact that the CDAI and Harvey-Bradshaw clinical indicators are poor subjective measures of Crohn's disease activity and their response to therapy. If we look at endoscopic evidence for predicting bad outcomes, if you think about colectomy as a bad outcome, which I would if I had inflammatory bowel disease, if you had deep ulcerations versus no ulcerations, your chance of having a colectomy at year 1 was 31% versus 6% in a collective evaluation of Crohn's patients in France. By year 3, they pretty much equaled out, but by year 8, obviously there was a significant numerical advantage of having no ulcerations versus having deep ulcerations when it comes to keeping your colon. So this is really one of the first pieces of evidence that suggested that being able to have fewer or a lower disease burden in Crohn's colitis was beneficial. Now, there have been multiple studies that have looked at that since then, and in this meta-analysis of 673 patients from 12 studies, we can see that 69% of the patients with mucosal healing at first assessment were able to maintain a long-term clinical remission compared to only 43% of the patients that did not have mucosal healing at their first assessment after initiating a therapeutic intervention. 94% of the patients with mucosal healing at the initial assessment maintained long-term mucosal healing compared to only 18% of the patients who had active endoscopic disease. And there were also trends to lower rates of surgery for this group of patients. So we have a couple of different pieces of retrospective data to be able to help us out with that. But this was a recent prospective study, the CALM study, that was evaluating 244 patients that had active ulcerations on their Crohn's disease who had just completed an endoscopic taper, a steroid taper, and they still had active clinical disease. These patients had not been on immunomodulators or biologics, and they were randomized to either tight control or clinical monitoring. I'm not going to go through all the steps, but their treatment with adalimumab could be followed by maintenance of the regular interval, weekly, or adding on azathioprine. And the primary endpoint at the end of the study was mucosal healing, based on the benefits that we know of. So if you look at the primary endpoint of mucosal healing with no deep ulcerations at week 48, you can see that tight control, monitoring C-reactive protein, drug levels, as well as fecal calprotectin was more advantageous than just using clinical symptoms to drive their changes in their drug regimen. And if you look at the secondary endpoint, various endoscopic and biological indicators of remission, deep remission, which would be considered to be clinical remission plus deep remission would be endoscopic plus clinical remission. You can see that tight control was superior to clinical management. Also, in the setting of biological remission, which is where you would actually have absence of biomarkers plus absence of clinical symptoms. And as we already alluded to, the endoscopic improvement was better in the patients that had the tight control versus the clinical management. But unfortunately, none of these even deeper indicators of remission were able to be shown to be significant. But if we look to see what happened over time, their observation was extended out to up to 3 years, and we can see that patients that had endoscopic remission in red versus the patients that did not have endoscopic remission in blue actually were much less likely to develop a major adverse outcome, which was defined as a development of a fistula, an abscess, a stricture, or perianal disease in Crohn's, in the setting of Crohn's disease, or having to undergo a Crohn's disease surgery. If we look at the deep remission, which would be the biologic plus the endoscopic remission, we can see that, again, the patients that were able to achieve this versus the patients weren't able to achieve this was highly significant, all the way out to 3 years after the initial randomization process. And the question is, you know, at what cost does this come? Is this more expensive to intensify therapy, or is there actually an economic benefit for doing this? So if you look at the direct costs, they were not significantly different between tight control or clinical management. And if you look at the quality, they were actually very similar to each other, so that you only had an incremental change in your quality of about 20,000 pounds, which is well within reason for making a recommendation for a change in your way of doing things. If we look at endoscopy as an endpoint for ulcerative colitis, again, this is a Mayo score showing severe colitis versus a normal patient. So we have mild, moderate, and severe. If we look at evaluating the risk of relapse in ulcerative colitis, depending on the degree of mucosal healing, so a Mayo score of 0, which is normal, versus 1, it's clear that, so 187 patients with ulcerative colitis were scored according to a score of Mayo 0 or a score of Mayo 1, and then they were evaluated over a 6-month period of time for their risk of relapse. The patients that had a Mayo score of 0 only had a 9.4% chance of relapse, versus the patients that had a Mayo score of 1 had about a 36% chance of relapse. So a significantly increased number of patients. The only factor that was independently associated with relapse was that Mayo score of 1. So medications, other things didn't really matter for these patients. If we look at histologic targets, though, actually taking endoscopy one step further and looking at mucosal remission, Stride's not quite up to the data at this point in time, because they were saying that it's not really recommended as a target because there's insufficient evidence. But I'm going to show you some of the evidence that's recently been generated since Stride to suggest that that may be otherwise. So we have a prospective study in patients with ulcerative colitis that were followed. These patients were in clinical remission. They were enrolled and followed for 12 months. They had baseline Mayo scores evaluated, and then a baseline histologic score by the Gebo scoring system. They also evaluated biomarkers. And then they were monitored for 12 months for clinical relapse, hospitalization, or colectomy. Both Mayo score and Gebo scores were significantly associated with the development of relapse, elevated Mayo scores and Gebo scores. But in a multivariate analysis, only histology predicted relapse for these patients. So a Gebo score greater than 3.1, which would be considered to be not histologic remission, was associated with a relapse about 3.5 times higher than if you had a Gebo score less than 3.1. And only 7% of the patients in clinical, endoscopic, and histologic remission actually relapsed over a 12-month follow-up. Another study was looking at this same concept, but based on a 6-year follow-up. And again, I'm not going to belabor the points because there are a couple of things that I want to get to, but there was a pretty good correlation here between endoscopic remission and histologic remission. But when we looked to see what happened for predicting corticosteroid use and hospitalization over a 6-year follow-up, mucosal healing was the only thing to significantly predict continued corticosteroid-free remission. And if we look at severe colitis and hospitalization, again, mucosal healing was the only thing that was able to reliably predict that, but it predicted it for all the way out to 6 years. And if we look here for histologic complete remission versus endoscopic remission, this is the difference for corticosteroid free hospitalizations and colectomy. Now, colectomy wound up not being a significant difference, but the event rate was also pretty low when we were talking about that particular event. So how are we doing in modern times with our newer therapies? We have a couple of interesting studies that have recently been introduced in the literature. So one of them is Varsity. It was a head-to-head biologic trial in patients with ulcerative colitis. We had 769 patients with ulcerative colitis who were randomized to either standard induction and maintenance therapy, either vedolizumab or adalimumab. And if we look at the primary endpoint of this study, it was clinical remission with a total Mayo Score of less than 2. Well, interestingly enough, we have a first where we have a superiority trial showing that one therapy was more beneficial than another therapy as far as being able to induce clinical remission. But as we've heard from some of the other slides, that clinical remission is not the be-all, end-all. It doesn't necessarily predict the ability to reduce complications down the road. So if we look at the ability of these medications to put patients into a Mayo Score of 0 or 1 at the end of 1 year, you can see that 39% of the patients that were on vedolizumab were able to achieve that versus only 27% of the patients on adalimumab. So these are standard dosage regimens for the medications. If we look at the patients that had not been on an anti-TNF therapy, we're actually getting fairly close to half of the patients able to get into that endoscopic remission. But if we look at an even better predictor of being able to avoid complications down the road, histologic remission, we can see that with this Gebo score less than 2, which is actually really, really low, lower than what we looked at prospectively with our other observational clinical trials, we did see a difference here between patients that were treated with vedolizumab versus adalimumab. But if we look at a Robarts histopathology index score, again, I told you there were lots of scoring systems, but this would basically be considered to be histologic remission as well. We were able to get a little over a third of patients into that histologic remission with standard medical therapy. And most of these patients were on monotherapy when we went forward. If we look at a slightly less aggressive measure of histologic remission, again, we see that we can actually get about 42% of the patients on one drug versus 25% of the patients on the other. So what I'm setting this up to say is that we're able to generate significant enough therapeutic deltas here to actually begin to use this as an endpoint for evaluating our clinical trials as we move forward. And the regulatory agencies are now beginning to look at that and actually include that as a primary endpoint, a co-primary endpoint that has to be satisfied before new medications are actually able to be approved for use in the clinic. If we look at other endoscopic endpoints here for another therapy for ulcerative colitis, that first was for Crohn's disease. This is for patients with ulcerative colitis. We were evaluating endoscopic improvement in the overall population. 44% at the end of 1 year were able to achieve a Mayo Score of less than or equal to 2 versus 23% of the patients that were initially given a dose of the ustekinumab and then re-randomized to placebo. But if we look at the combination of endoscopic improvement plus histoendoscopic mucosal improvement, we can see that at week 8, only about 25% of the patients that were on medication were able to achieve that versus 13% of the patients that were on placebo. But by the end of 1 year, we now have this re-randomized population that got randomized from ustekinumab to begin with to ustekinumab on a chronic basis. 47% of the patients are in this histoendoscopic remission or improvement. versus 27% of the patients that were on drug to begin with and then re-randomized to placebo. So continued medication actually continues the histologic as well as endoscopic remission. And again, we have a therapeutic delta of 20% here, which is a number needed to treat of 5, which is pretty considerable to have a very deep endpoint. And again, should inform our economic analysis for these things. If we look for novel therapies, just real quick, we know that white light endoscopy, which is what we've typically used to do colonoscopies, is not as good as high definition white light endoscopy. You can see the difference between the two here. But if we start to use things like magnification view, we can actually start seeing the actual crypts that are associated with the intestinal epithelium in the colon. And if we put methylene blue in, use a magnification endoscopy, we can actually begin to see the crypts in as much detail as we can with histology. And so with endoscopic improvements, we may be able to now make a leap forward where we're able to evaluate this endoscopic response to medications in a much more detailed manner that may be much more meaningful than just a Mayo Score of 0 or 1. So next steps that we have to do. We have to apply these new or endoscopic technologies to inflammatory bowel disease diagnostics and monitoring. And this is the magnifying endoscope that actually has a microscope in there. You put it up against the mucosa and that transmitted light will come back to the lens and pick up individual cellular components, and you can magnify up to 500x. We also need to start looking at other non-invasive technologies because, again, patients don't want to go through multiple colonoscopies if they can avoid it. So we're now showing that MRE may be as effective as endoscopy as far as showing response to medications for Crohn's disease especially. But something that I'm very interested in is the application of ultrasound to abdominal ultrasound to measuring inflammatory bowel disease response. They're doing a lot of this in Europe now and have shown very good correlation with endoscopic improvement. So we need to develop electronic means of implementing this reiterative testing to documentation outcomes for our quality systems. So our EMRs are not able to accomplish this at all. And we need to make major changes to be able to evaluate these things and understand what the results were so that we can make the next best decision for a patient down the road. And then we also need to augment centrally acting immune therapies with things that are going to help protect our mucosa as well. So in conclusion, we should be using more effective medications to enhance mucosal healing. Prednisone and azathioprine don't do it anymore. We've got to increase the defense spending. We've got to start buying the biologic weapons here against inflammatory bowel disease. In addition to clinical monitoring, we should be monitoring both endoscopic and histologic remission. So if you have somebody that's not doing that, they're probably not keeping up with the best practices. Our goals to treat the target will evolve with new technology. We talked about some of those things. And we really need economic analyses to be able to support the optimization of these therapies, given the high cost and the high preponderance of utilization of these therapies for our problem child Crohn's patients and ulcerative colitis patients. So I think maybe we have a couple of minutes for questions. Thank you for your attention and learning a little bit about IBD.
Bruce.
Sure. Right. So, I mean, we know that some patients with anti-TNF, which is a medication to treat psoriasis, can actually exacerbate or initiate the development of psoriasis in patients with inflammatory bowel disease. So there's probably a threshold, a layer of TNF that you need to be able to actually reconstitute your bowel wall as well as your skin epithelium. But in the setting of some of our more advanced therapies where we're talking about anti-IL-17 versus anti-IL-12/23 molecules, if you neutralize IL-17, which is an incredibly effective strategy for psoriasis, if you listen to the small talk at the end of those advertisements on TV. They say, do not take this if you have inflammatory bowel disease, or if you don't have inflammatory bowel disease, you might after taking this medication. And that has to do with the fact that the major players that are causing the inflammation, these Th17 type T cells that are secreting large amounts of IL-17, are actually stimulating what I call Newton's law of immunology. They're stimulating an equal and opposite reaction. So for every inflammatory reaction, there's a restitution or an anti-inflammatory reaction. And the secretion of IL-17 will stimulate the upregulation of IL-22 production. IL-22 is very important in the gut and being able to maintain restitution. And so if you destroy that or prevent that from occurring, then you actually maintain gut porosity, and that winds up stimulating the GI tract. So why it works well with one disease, but not necessarily another, because the immunological systems are a little bit different there. Thank you. Nathan. So biosimilars could potentially drive the cost down, but unfortunately, I mean, biosimilars are generic forms of our original originator, what they call the originator. So Infliximab has multiple biosimilars. Humira will have multiple biosimilars coming down the track. In general, they have been priced pretty close to the originator price, so they haven't really driven down the price. That has to do with government pricing policies and things like that. But what happens is the company with the originator will then cut costs to match or go below the biosimilar cost. And so I think that eventually there may be some pricing wars, perhaps, that will drive these costs down. They're still expensive medicines, though, and we'll see. The economic analysis need to be done to be able to justify their continued utilization. Right. So, I mean, if you have an absence of those predictors of severe outcomes, then you can assume that those are probably especially if they have mild symptoms and mild endoscopic findings, you can assume that those are the patients that aren't going to have complications and are the ones that you can take things a little bit more slowly. You know, you can put them on budesonide, maybe put them on steroids, maybe add azathioprine if they become steroid dependent or steroid refractory. So you have the tincture of time associated with those guys, but if you have those warning signs, those warning indicators, those are the patients that you need to take seriously and be aggressive with out of the box.
Ed, I have one question from a
Sure.
practical standpoint. Most of the patients that are hospitalized that we see give IV fluids, control their pain, put them on steroids, and then switch them to oral steroids. Hospitals don't generally start the anti-TNF medications in the hospital. Again, that has pricing. And while we're in, you all know you have to get the TMPT level, you have to check a quantiferum, you have to make sure they're immunized to hepatitis A and B, give them immunity. What else we should be doing? And is there a problem with once you discharge them? I mean, how soon should they really be where they're going to have initiation of biologic therapy? 2 to 6 weeks?
Yeah, I think it's certainly, I mean, again, if you go back to the treat to target, your treat to target paradigm suggests 3 months in between therapy, but that's with effective therapy. So, steroids are still a bridge. They're still a Band-Aid to put on.
That's all we can do in the hospital.
Right, exactly. Unless they have severe ulcerative colitis that's steroid refractory, then, it's still a struggle. But definitely steroids within 2 to 3 weeks is probably a reasonable period of time. You could even talk to, say, if you're sending them to our clinic, talk to the nurse that takes care of these, Chris Kerr, and she can initiate the explanation or exploration of benefits, prior authorizations. Insurance companies often don't want to pay for these, and they will use every tactic that can. But you did harp on one thing that I want to caution the audience about. You said control their pain. Please, please, please do not use narcotics, okay? If you utilize narcotics in Crohn's disease, narcotic use or co-administration is associated with twice the risk of death in Crohn's disease. And number 2, these are chronic disorders. And just a couple of days of narcotics can be enough to initiate that dependent cycle for these patients that is going to perpetuate itself in the emergency rooms, in the clinics, They're going to get addicted. They're going to stay addicted, and it's going to complicate their treatment down the road. So please, please, please avoid narcotic initiation.
I do feel sorry for our medical colleagues to hear that, but it's also why we say we're not going to manage their pain other than with their treatment.
Right.
Because if you manage both at the same time, you actually don't really know whether or not it's the steroids making them better and you've got a treatment response, or whether it's the IV Dilaudid. So I completely agree with that.
Yeah, and when they start having pain after they leave the hospital, is it withdrawal from their narcotics? It's quite possible. Fortunately, there is some relief. Dr. Yakishin is familiar with the product from a company called Arena that is a non-opioid pain medication that's being actively evaluated in patients with inflammatory bowel disease, has shown some promise. So hopefully we have some other things coming down the road that will be adjunctive medications to be able to help us manage these patients more appropriately.
Otherwise you use tramadol?
Even that can be problematic, and it can initiate that addiction cycle. But yes, I have been known to use some tramadol.
Because we don't really want to use NSAIDs either, so it's a problem. So I did want to bring that up as a problem.
Yep, thank you.
Sorry, any other questions? There's a question. Yes, Dr. Omer.
Synergy between adding, that's really increasing the defense spending. And yes, we are doing a clinical trial right now. If you have patients who are new onset Crohn's disease and they have multiple indicators of, this debilitating course, we are doing a study where we're looking at vedolizumab plus adalimumab for induction, plus methotrexate, plus prednisone, to try to get them into a deep remission and then maintain them with one biologic moving forward. So if you have patients like that, please refer them to the coordinator. We would love to be able to fill that study up. It's a little slow going, but it's great because it's open label and they know they're going to be getting those drugs. And they might be getting the best care possible. We don't think that there's a significant impact on the overall side effect profile by adding on biologics at this point in time, though. We don't know what the upper level of safety is, limit of safety is on these, but apparently it's much higher than we have been reaching with the standard dosing of our medications. Okay. Yeah, so there's very little data utilizing things like cyclosporin, Prograf, the tacrolimus, those types of inhibitors, T-cell inhibitors. They're working on some of the same T-cell populations that are causing a problem. The problem is that they have other target side effects, and they also can potentially be a little bit deeper immunosuppression than some of our biologic therapies. So there's limited data. Generally, cyclosporin doesn't have long-term benefit in the treatment of ulcerative colitis. There are some suggestions that you can use mycophenolate, Mofetil, for some patients with Crohn's disease on a chronic basis. They are doing that in some centers. But for the most part, there's just a very little bit of data to suggest their benefit in IBD.
Okay, the hour is late. Thanks for the great discussion.
Thank you.
Any more questions? Come and grab him.
Sure, thank you.